this is Selma Schimmel for the group room at the ESMO 2012 Congress happening now in Vienna. And now we are joined by Professor Michele Ghielmini, who is a professor at the University of Bern and medical director of the Oncology Institute of Southern Switzerland. Welcome, Professor.
Hello.
We're going to talk about diagnosis and management issues in lymphoma.
We thought that this year it was important to illustrate what's coming new, because in the world of lymphomas there has been kind of a stagnation for the last 10 years, and now there are new drugs coming, so we had the impression it is now time to illustrate what there is around.
If you could highlight some of the aspects of the talk, your session, what was presented there, it would help us a lot, and maybe the bullet points of what you feel are the most compelling points that patients need to know.
We have in the lymphoma family, we have diseases that are almost not treatable yet. We can treat them a little bit, but we don't change very much their prognosis. And we have other lymphomas, like Hodgkin's lymphoma, which are nowadays curable in almost the majority of cases. So this evolved during the last decades, and let's take the example of this evolution from diffuse large B-cell lymphoma, which is the most frequent lymphoma. So the first drugs that functioned there were alkylating agents, and when these were introduced, survival was prolonged by a few years, but nobody was cured. So this was the first step. The second step was the introduction of doxorubicin, and this could cure patients. So we, for the first time, saw a plateau in the survival curve. And then the third step was the advent of rituximab. Rituximab cured more patients, and so the level of the plateau raised by about 15 to 20%. And now what we need to do as next step is to raise this plateau completely to 100% and to do what we have already almost achieved with Hodgkin's lymphoma, to cure almost all the patients. So we have diseases like mantle cell lymphoma, for example, in which patients, the median survival is approximately 4, nowadays 5 years, and rituximab has prolonged it a little bit, but we are still desperately looking for the drugs which could prolong by years this survival. And the next step could be applicable, for example, to indolent lymphomas, like follicular lymphomas. For these lymphomas, we have already prolonged the survival to approximately a median of 10 to 12 years, but we want now to prolong it to 15 or 17. And here again, we want the new drugs to do this. Then we have, for example, we have peripheral T-cell lymphomas. These are a lymphoma family that is curable, but only in approximately 20 to 30% of cases. We want this percent to go up to 50 or 60%. And then finally, as I have cited already, we have the Hodgkin's lymphoma, in which we cure maybe 90% of the patients, but they have long-term side effects from the treatment. So for these patients, we want to get to 100%, and particularly we want to find drugs who do not have long-term side effects. Now, which are the most important drugs? Well, there are a number of them. There are several new families of drugs. There are drugs acting on the tumor microenvironment, like, for example, lenalidomide. There are histone deacetylase inhibitor who do act on how the DNA is structured, and it tries to interfere with the structure of DNA. So silencing or activating several genes that can be important for tumor development. But I think at the moment, the most important or most interesting drugs are two categories: the immunotoxins and the small molecules acting on the B-cell receptor pathway. Immunotoxins, they come from a development of antibodies like rituximab. Rituximab functions directly, so it attaches to the tumor cells and it makes the tumor cell recognizable by the immune system. You know, it tells to the immune system, hello, I'm here, you know, come and get this cell. But the immunotoxin is the same antibody to which a toxin is attached, And so what it does, it goes and attaches to the tumor cells, and then it brings the toxin inside the cell, only inside the tumor cell. So it is kind of a targeted chemotherapy. Chemotherapy goes all around the body, while the immunotoxin only goes to the tumor cell, brings the chemotherapy inside the tumor cells, and all the other normal cells are spared. So now this sounds nice, but does it work or not in the patient? And the interesting thing is, in the last year and a half, several immunotoxins have been tried on patients, and they have been shown to work. The first one has been now licensed in the United States, is brentuximab vedotin. It is a drug that functions in lymphoma cells who do express CD30 on their surface. So it's especially Hodgkin's lymphoma or anaplastic large cell lymphoma. And in these patients, even when they are in relapse, even if they are in relapse after transplant, so really bad prognosis patients, more than 50% of them do respond to these immunotoxins. And we have other immunotoxins that work more or less the same way, that have shown activity in follicular lymphoma, in mantle cell lymphoma, in chronic lymphocytic leukemia. So this is a very promising category of drug.
Are there any updates in the area of Hodgkin's disease?
The big breakthrough is what I was just saying, is the immunotoxin brentuximab vedotin. After maybe 30 years that we didn't have anything new functioning in Hodgkin's lymphoma, this immunotoxin has brought really a big hope, because it works also in patients who do not respond to chemotherapy anymore, also to patients who relapsed after autologous transplant. And at the moment, this drug is being combined with chemotherapy with the hope of ameliorating the results.
Thank you. Thank you so much. Professor Michele Ghielmini, who is a professor at the University of Bern, medical director of the Oncology Institute of Southern Switzerland. Thank you for giving us an update and a bird's eye view into your world of hematology here at ESMO.
Thank you.